Now, moving on to our first section, that is what are the complications and general complications associated with fractures. We'll be discussing visceral and nerve injuries in this section mainly. Now, what are the general complications? This could be as simple as blood loss. If the patient had, for example, a trauma, especially associated with the shaft of femur fracture, a shaft of femur can has as high as almost 1 to 1.5 liters of blood which can be lost. Similarly, a shaft of tibia fracture can be maybe up to 500 to 1 liters or 500 ml to 1 liter of the blood can be lost. So the most complication is actually the blood loss, which actually leads to another kind of a complication, which is a shock. The most common type of a shock, especially associated with musculoskeletal trauma, is the hemorrhagic shock or hypovolemic shock, because there is a massive amount of just blood loss, especially if it is associated with pelvic trauma. Pelvic trauma can have up to 2 to 3 liters of blood loss, and patient may be in a profound amount of hypovolemic shock and may require very aggressive resuscitation with in form of fluids, bloods, and may need external fixation as well. Now, the other complications which could be, as you know, that usually these are the long bones, and which contain they have a medullary cavity and they contain fat in form of a bone marrow. So when this disruption occurs at the level of the diaphyseal fracture, especially the long bones such as femur and tibia, and the most commonly it's with the femur, the fat embolism is one of the very rare but very lethal complication which can happen associated with long bone, mid shaft or diaphyseal fractures. And lastly, it could be cardiorespiratory failure. Now, all this loss, blood loss, hypovolemic shock, fat embolism, all this can contribute to cardiorespiratory failure. But eventually, it's not the isolated, which is the cardiorespiratory failure results from basically the fracture, but there are multiple other factors which contribute to it, eventually leading to cardiorespiratory failure and mortality of the patient. Now, coming to the local complications, which could be over there on the, for example, the patient have a limb, upper limb or lower limb fractures. What could be associated with that? It could be early and late. Early is actually further divided into urgent and less urgent. Urgent means you need to do something about them. You cannot just wait for there and maybe for weeks or months and eventually it's going to heal. The most urgent is a visceral injury. If it's, for example, if it's a pelvic trauma, there may be multiple fractures as well, and there could be associated with genitourinary injury. There may be bladder rupture, there may be urethral rupture, there may be ureters may be damaged as well, and you need to deal with them, because otherwise that is going to cause severe peritonitis and eventually the patient is going to die. Second is vascular injury. A shaft of femur, for example, if has distal femur or in the proximal 1/3 of the femur shaft fracture, may lacerate the femoral artery. Now, this results could be disastrous for the patient. Eventually, the patient may lose his or her limb, because vascular repair is foremost important. Otherwise, you cannot wait for it. Next is nerve injury. Although it can be as disastrous as anything, but the only problem with the nerve injury is you do not need to intervene straight away. But this is one of the very urgent complications which can result in, which may be associated with fractures. The more other common include is a compartment syndrome. If it's a polytrauma patient had multiple injuries with associated soft tissue injury as well, and there may be all this leading to massive amount of swelling, and there may be a developing compartment, which eventually can compromise blood and neurovascular supply to the area and eventually lead to gangrene. So other is infection. Infections is especially more of a threat when we are dealing with open fracture, especially when the patient had some kind of farm injuries in which the patient was either thrown out of the car, or the patient had sustained injury, which is where there is a lot of dirt or debris present in the wound as well. And lastly is the gas gangrene, especially associated with the farm injuries, because Clostridium difficile and Clostridium welchi, these organisms can thrive in anaerobic environment, and their thriving can actually lead to gas gangrene development. So infection and gas gangrene is something we need to be very sure when we have to deal with that when we're dealing with open fractures. Less urgent includes actually fracture blisters, which we need to treat it conservatively. Plaster and pressure sores, although it's more of a iatrogenic injury because it's associated with the one who's actually applying the plasters, but this can be very damaging as well. And there is specific techniques for applying plasters, because applying it in the wrong way can lead to plaster blisters and all this. Heterotopic ossification is usually associated with post-traumatic injury, and this leads to calcifications around the joint, especially between the muscles and the synovial cavity. But actually, what happens is this: not everybody gets this disease. Some are more liable and prone to getting heterotopic ossifications, other usually don't. Then it could be a ligamentous injury. If we are dealing with knee injury, this could be later on manifest as knee instability and will require some amount of management in form of operative arthroscopy, so that ligamentous injury can be later on dealt with. Tendons injuries is also rare, but yes, it is common as well, and this can later on may require operative fixation as well. Then other is nerve compression, joint stiffness, and complex regional pain syndrome. These are what may be associated with post-traumatic areas and may sometimes require only conservative treatment in form of indomethacin and analgesics, or may require surgery. Now coming to the late complication. There was fracture, you fixed it either with internal or external fixation depending upon what was the situation and what was the Castillo grade at the time of presentation. Then what happens? There could be a delayed union. That you know that union is going on, but it's delayed at 6 to 9 months. Or it could be a non-union as well. At 6 months you see no sign of union at all. Or why, yes, you have applied a plaster, but eventually it's a malunion. For example, the distal radius fracture, POP was applied, but later on there is increased angulation, either as varus or angulation or dorsal angulation, and this is actually creating problem because the patient is not able to achieve the range of motion he or she needs for the activities of daily living. Then it latent complications include avascular necrosis, growth disturbances, which may present as limb-length discrepancy. If the patient was given a POP and patient is bedridden, for example, for some time, this may lead to bed sores, or even the problem is the muscle contracture, joint instability, and eventually post-traumatic osteoarthritis is one of the very common cause, because the injury at the time of trauma can eventually lead to osteoarthritis later on in months to years to come. Now coming to the early complications, as I told you, most common is visceral injury, which could be a penetrating of the lung with a pneumothorax, or a hemothorax may develop, usually a rib fracture which can damage the neurovascular artery as well. Then this could be, especially if it's a pelvic trauma, it could be associated with a rupture of bladder, urethra in the pelvis, and may require early recognition as well. For example, if there is perineal ecchymosis, the scrotal swelling, and there is blood in the meatus, one must suspect urethral injury and requires emergency treatment as per ATLS guidelines. Now coming to the vascular injury, what are its clinical features? Clinical features of the vascular may include paresthesia, the numbness of toes or fingers, because nerves also get dysfunction as well. Injured limb may be cold and pale. Pulse is either weak or absent. There is usually associated with high risk fractures. For example, we know certain type of fracture associated with certain type of injuries. For example, pelvic injuries may be associated with iliac arteries, or distal femur fracture may be associated with femoral artery injury. The vessels may be blocked by a thrombus, or there may be a segment of artery may be in spasm, which may lead to this kind of a problem and may lead to profound ischemia, tissue death, and peripheral gangrene may ensue if the time increases from more than 6 hours. So if it's a vascular injury, you need to operate within 6 hours limit so that you can get maximum results. Coming to the common vascular injuries, for example, with the first step, maybe a subclavian artery may be damaged. With the shoulder dislocation, axillary can be damaged. Usually it's the anterior, but if it's a posterior, then it can damage axillary artery as well. Coming to the humeral supracondylar fracture, the brachial artery may be damaged as well. Elbow dislocation may be associated with the brachial artery. Pelvic fractures may be associated with parasacral or iliac arteries. Femoral supracondylar fractures may be associated with the femur artery. Knee dislocation can be associated with popliteal or even the femoral as well. Coming to the proximal tibial, popliteal and its branches, any of them can be damaged as well. So this can kind of precipitate either a compartment syndrome or associated vascular injury. Now, if there is a vascular injury, what to do with it? Now, the point is, either it's the vascular. Now we have to understand this, that there's a frank vascular injury at the time of the trauma. For example, there was a laceration of the artery by the bone ends, or this could be due to the hematoma formation and bleeding over there. This hematoma may be compressing the arterial supply. So the first and foremost is the removal of the bandages and splints removal, so that maybe once the swelling settles down, the artery eventually the supply is restored. There could be a prompt reduction if artery is compressed. Then there may be a reassessment of the circulation. We need to look at it, the cause, what could be the cause of the problem, and we may have to go for preoperative or perioperative angiography. Now, angiography would tell us whether there's an outside hematoma which is compressing the artery, or is it just laceration of the artery itself. And then if it is, the artery is damaged, then we need to repair it. Now, repairing could be a simple anastomosis of the both ends if it's a very small segment. If a large segment is involved, we may need a venous graft, and endarterectomy can only be done if there is the presence of thrombosis. But that is something angiography would tell us whether there is thrombosis, there is a cut end, or there is actually a hematoma compression. If vessel repair is undertaken, we need to have a stable fixation. Now, the point is, bone must be fixed before the vessel repair is done, because that is all usually in form of external fixator. And once we apply the external fixator, the vessel is repaired, and then we wait for the limb to return back to normal. And once patient is out of that period where the gangrene can occur, there is no gangrene which has occurred, and vascular graft or repair was successful, then we can go for internal fixation, which can also be done, but that is at a later stage. Now, coming to the nerve injury. Nerve injury is particularly common with the fracture of humeral shaft and injuries around the elbow or the knee. Usually there may be closed nerve injuries, there may be open nerve injuries, and acute nerve compression, because of the hematoma may compress the nerves as well. So what are the indications for early exploration? Usually nerve injury may be associated with open fractures, because when you are going for the vascular repair, if you can repair it there, then you can do this. Nerve injury with the fracture needing internal fixation, presence of concomitant vascular injury, and nerve damage diagnosed after the manipulation of fracture. For example, there was a supracanal fracture, you manipulated, close reduction resulted in actually the nerve injury. Then you need to repair it, because otherwise this can lead to disaster. What are the common nerve injuries, for example, associated with this is shoulder, it's axillary. The humeral shaft fracture is radial. Humeral supracanal fractures may be radial or median, but radial is more common. With elbow medial condyle, it's always the ulnar, which is passes just below the medial condyle. The Monteggia fractures is usually associated with posterior trochleus. The hip dislocation, there is a sciatic nerve, and with knee dislocation, usually peroneal nerve may be involved. And all these common nerve injuries have a different way of. If it's a closed nerve injury, there's a different mechanism. We wait for the actually 3 to 6 weeks. We get an ultrasound at 3 months. We decide after getting NCS and EMGs whether we have to operate or not. But if it's an open nerve injury and if it's post manipulation nerve injury, then we may have to operate early, so that we have to reduce the compressions which is acting on the nerve. In this section, we have briefly gone through what are the most of the common complications which may be associated with the fractures. There could be early complications such as blood loss. They could be leading to hypovolemic shock, and they may be associated with profound shock and loss of blood. Then this can also lead to cardiorespiratory compromise or cardiorespiratory failure. One thing we need to remember is that as there are usually long bones and they have a medullary cavity which contains bone marrow, and bone marrow is mainly made up of fat. So fat embolism is, although very rare, but very lethal complication associated with long bone fractures. Thank you very much. Keep watching sqadia.com.